Frank, are you there?
Yes, we're here.
All right, excellent. Tell us about your patient.
Okay. I chose this patient today because I'm actually going to give a talk on gender and peripheral arterial disease. And this lovely lady is a super great example of that. So we have a 62-year-old female with complaints of bilateral lower extremity numbness, tingling, and some pain for about a year. She actually denies claudication, but functionally she doesn't do much. So she complains that her legs are very weak and tired. She lives with her mother, and her mother states that she just doesn't get out much anymore. She doesn't go shopping, she sits around the house, watches TV. She has a pretty significant past medical history, including stroke and hypertension, diabetes, atrial fib, COPD. She is a current smoker. She's on good medical management for all her medical conditions, including aspirin, Melinta, lisinopril, metformin, and rosuvastatin. She was worked up with arterial duplex after we saw her in clinic. She has bilateral SFA occlusion, very the eyes are low. And we actually treated her left leg about 2 weeks ago. And she had a CAS D lesion, which is a very long segment lesion of her superficial femoral artery, which we were able to treat with balloon angioplasty and stenting for great results. So today we're hoping for the same on her right leg.
Excellent. You know, one of the thoughts behind this is to show our colleagues, kind of what we end up doing every day, and to at least see in the operating area kind of what we see for some of your patients. And the advantage of that is that you get to talk to patients about maybe what to expect if they do need a procedure. We're constantly trying to avoid operations if we can, avoid more serious operations. We do more surgery now with the endovascular options, where we can enter into a small vessel either at the ankle, which looks like Dr. Frank has done so, and then we can move along the leg to where that disease is.
So we've gained access at the posterior tibial artery on her ankle. She's fairly calcific. We have a wire up now and a catheter up into her common femoral external iliac artery on the right, and we're about to shoot our initial angiogram. Again, we see extremely calcific superficial femoral artery there, which looks fairly diseased, and we're going to come down and shoot the remainder of the artery. And run. We see some pretty excellent collateral coming from the profunda femoris. We do see a pretty long segment, chronic total occlusion of the superficial femoral artery. So pretty much she's matching, her legs are matching in pathology. Keep coming down, we'll probably see where she comes back. Run. Again, her collaterals are filling what appears to be the distal superficial femoral artery and proximal popliteal artery. I'll come down a little bit more.
So one of the things I think you're showing very well is that the profunda femoral artery is the dominant collateral in the lower leg, and that's at the common femoral artery divides into the superficial femoral and the profunda. And if we have a robust profunda, that develops all the side roads to get blood to the lower leg if the SFA is occluded. And this is why people get the claudication effect. So when they walk, they get the cramping in the calf muscle. They run out of blood because they're not able to get enough blood down to the calf during that time. And they run out of oxygen, so they start to cramp and hurt. If they rest for a few minutes, the profunda can drive the blood back to the calf again, and they can walk again. So it's always a walk, rest, walk cycle. And part of, I think, our job is to reconstruct people so that they can actually physically exercise. If they can't exercise, they can't keep their heart strong, lungs working, muscles strong.
So you can see here, she comes back. She has small arteries everywhere. However, her popliteal artery looks like it's filling nicely. And so the main concern here is the superficial femoral artery in its entirety. So we have already administered our heparin. We're going to keep this. Take a 300 water. So we're going to probably start off here with a balloon angioplasty of this vessel and see how that works, and then go from there. Let me push it all the way up. Keep coming up to the wrong, please.
Frank, you're a history buff. Is that true?
A little bit.
I listened to your lecture yesterday, and it was full of different, very interesting, medical facts and how things started. But heparin was kind of created in the 50s.
Yeah,
and isolated.
50s. Yep.
And I think that's when the genesis of vascular surgery started. When I think we had 3 surgeons claim they did the first carotid endarterectomy, because that's surgeons. That's what we do. That's a mindset. But heparin's a critical part of this, and it really allows us to work within the vascular system and repair things and fix things now. Traditionally, it's been always open surgery in my early training, but since 2000, endovascular therapy has dramatically increased and improved our ability to tackle disease.
Yeah, I believe they started sourcing heparin from horse liver, and then it kind of graduated to porcine intestine. It was really a huge part of being able to do these cases successfully. So we're going to, we're putting on our 4mm balloons. It's a very small vessel, so we're using rather smaller size diameter balloon.
So what's your thought process here, Frank? You want to angioplasty the lesion at this point?
Yeah, so the process here is we're going to angioplasty the lesion. It's a very small artery. We had a chronic total occlusion here. So my wire, I know, is not through the true lumen of the artery all the way up. There are some parts of this crossing this lesion that are in the subintimal section, but that's okay. And we're going to balloon that segment and prepare it for potentially using a stent here.
So I think that's an important distinction. Now, maybe that is more specific speak to surgeons and how we think about things, but arteries are kind of like onions. There's layers to the arteries, and we can get in between those layers sometime to travel along that layer to get back into the main flow channel, and that's what Dr. Cuozzo was describing.
We're going up with the balloon now.
Now, most of these patients are treated in our outpatient facility. At least this is where this is live from, and we do use anesthesia and conscious sedation for control of anxiety and pain. And it's tolerated very well, but we also keep people fairly light because we want that feedback. And if someone's having pain when we're doing an angioplasty, that will give us a sense that maybe something is happening that we don't want to happen. But it sounds like she did pretty well with that angioplasty.
Yeah.
Now, we do wait for 2 minutes. It's the longest part of our day because we're trying to break the bonds of this calcium that is developed. And if we took the balloon down immediately, there would be a significant recoil, meaning the artery would kind of collapse back on itself. But we've learned over the years that if we have a good angioplasty that lasts about 2 minutes, then we can kind of break those bonds, and the vessel will stay open better for us.
All right. So we've taken this balloon up to about 4 millimeters. The balloons vary in size depending on how much pressure that you put into them. We're just being really gentle here, and we'll see how we did.
Frank, was that a Dr. Harris 2 minutes?
Yeah, maybe, yeah, midway somewhere in there. It's a chronic total occlusion of the majority of the SFA.
So Frank, what are your options at this point? Once you do the angioplasty, take a picture, and then what do you think?
Yeah, so our next steps here is once the balloon goes down, we'll take the balloon out, we're going to put our catheter back up into the common femoral artery. We're going to take pictures and take a look at vessel patency. Things we'll be looking for is residual areas of stenosis, areas of potential dissection, which is a real risk here especially when you're in the subintimal plane, you're actually, already technically dissecting the vessel. And so we'll be looking at all those things, and those things will be indicators of needing a stent as the next step here.
So we'll see that with traditional angiography where you inject dye. Are you going to consider IVUS to look at this as well?
Yeah, we can take a after we take a picture here, we can look with IVUS for sure and kind of see exactly the inside of the vessel and where the problem areas are. All right, go all the way up to the top, please. Come on down.
Okay, so the question was from the audience, what's the deciding factor whether we do just angioplasty or if we put a stent in? And I think that, Frank, what's your deciding factor between angioplasty and putting a stent?
So I really think, and we'll actually see here, we'll see how it looks on completion angiogram. And if we have a smooth, patent, open vessel with no areas of dissection, then we will, not likely place a stent to a line. However, if we, have residual stenotic areas, or we have a, flow limiting dissection, then yes, I think the stent is indicated. Let's take a look at this again right here. We're going to just touch our arteries just a little to get the catheter out of the way. Go ahead and front. That's actually
looks good, Frank.
Yeah, that's actually a pretty nice result.
Is there a lesion at the bottom of the screen there?
A little, yeah, and/or there. Actually, it's a dissection right there. So let's keep going down. I think we are going to probably treat that with a stent, but let's see what the rest of it looks like. This is exactly what happened 2 weeks ago. We did pretty much the same thing, and she had some areas of dissection that we stented. Yeah, so that's going to need a stent as well. So that's a pretty severe dissection there. And so let's see how far we need to put the stent. Let's come down a little bit further.
So the goal is to get to a point where there's no restriction of flow along that vessel to the lower leg, to vascularize the lower leg. And
there we go.
Always trying to prevent complications such as embolization, where plaque can break off or travel.
So that's pretty nice. So that's where we're going to start. See the marker, please. Okay. So yeah, we'll open the stent now. We're using a 6 millimeter Mazzago stent by 150.
Now, a lot of the stents that we use have all gone through FDA approvals. They all have specific indications of where to use, how to use. The Mazzago stent is designed specifically to deal with the popliteal artery, and kind of where that wire crosses the femoral, the femur. That is the kind of the division between the superficial femoral and the popliteal artery. And the popliteal artery is very mobile. We bend our knee, we sit down. There's always areas of that are always undergoing torsion, rotation, compression, and so you have to have the technology to actually combat that.
So we're preparing the stent now on the back table and about to place it here.
There are various techniques at trying to fix these arteries. Let's say the patient has a nickel allergy, because this is a nickel titanium metal stent. We don't want to put a nickel stent in somebody who has an allergy. And so there's other options called atherectomy, where we remove plaque and use a gentle angioplasty. And so we try to tailor the therapy to specifically the patient that we have on the table. So what are you doing now, Frank?
So currently we are now deploying the stent. You see the stent is deploying from the top to bottom here. You can see the stent, hopefully you can see the stent opening. We've just completely deployed it. You can see there's a little bit of a tight stenosis there still. So we're going to go back in with our balloon, go on, and treat that with a little angioplasty as well. So we call that post-stent dilatation.
Now, this metal is very interesting. It's a space-age kind of technology. NASA was very interested in metals that could respond, change size according to the temperature. And so these stents are actually designed to open at body temperature. So they're set at 6 millimeters, but they come into us, they come through the patient on a small straw, like a catheter. And then we pull the straw back, and that just exposes the stent, and the stent will then expand. So this is an expanding, self-expanding metal once it hits body temperature.
You can open it. Mm-hmm. Absolutely. Actually, hold on. We're going to take a picture up top.
Is there any other questions from the audience at this point?
Because we may not have that. May have that light. We'll see. Yep, looks like the balloon. We're going to post angioplasty the stent now. Thank you. Live. Okay. Essentially what we're doing now is lining up the balloon inside of the stent here. We're going to take this up.
One of the conversations I have with patients preoperatively, especially if they're very sedentary, is I say, listen, I can probably fix the plumbing, but if we don't fix the movement, then me fixing the plumbing doesn't change anything. Right. They have to be able to walk and be active afterwards, and sometimes they physically can't walk, and so by fixing this, that can allow them to do that.
Can the stents get re-occluded?
So can the stents get re-occluded? Sure. Atherosclerosis is a all-over body kind of process. If the risk factors are not addressed, if they continue to smoke, that tends to be a population that has a higher risk of recurrent disease, and not only in the artery or the stent that we worked on, but other throughout the body. And sometimes we have to deal with that, and so we can go back and repair stents, but most of these patients will be on an antiplatelet therapy, dual antiplatelet therapy for, if not life, at least a year. And then we're aggressively dealing with risk factors. So, if their sugars are 300, no matter what we do as a vascular surgeon, I have to have the sugars back under control. So we definitely need risk factor management with primary care. We work on that as well, and just try to keep that patient moving in a good direction. But their sugars have to be under control. The smoking needs to stop. We have pretty tough conversations about that.
Give me a bag.
But you know, one of the things I've found as a physician for 20-some years is it's important to connect to a patient first. Once they trust you, then they can start listening to you. And that's when we have conversations about, hey, it's time to start cutting back on smoking, time to start getting rid of smoking, and then going through the process of it, because that's critical for longevity of this.
All right. So what we're doing here now is, you know, Dr. LeSar mentioned before the importance of this profunda femoris artery. And you can see it here. It is just very large, very healthy, and it's really what's been supplying doing the main work here of perfusing the leg. And we do have a pretty significant dissection here in the proximal superficial femoral artery. So really the one thing that we want to be careful here is we want to treat the superficial femoral artery, but we do not want to sacrifice this profunda femoris. So it's very important that we see the anatomy up here and that we stent to where we need to stent to with the goal of not covering our main artery, the profunda femoris. You know, because even if this stent goes down, her leg is still going to remain viable because of these amazing collaterals that she has. Can you push the screen for you?
So we've had some conversations with patients where they have a stent in, they're doing well, or walking, things are going well, and then sometimes they re-occlude or they re-narrow. We definitely go back and try to fix some of those things. We know that you're going to live longer if you have a good heart, good lungs, and strong thighs. Those three things equate to longevity. And so being active, being able to walk is critical for our PAD patients. I tell patients at least 10 to 15 minutes of good, aggressive walking a day, and I'll take more. But sometimes they can't walk 100 feet. If you can't walk 100 feet, you can't exercise. And so by giving them that ability and then the encouragement to actually change their movement, that's where I think we can be impactful.
So we are chosen another stent and are going to place this here as near as we can to the takeoff of the profunda femoris artery. Thank you.
So as Frank's doing that, you know, sometimes we have patients that go to the extreme where they have failed a number of times with the stent therapy, and then, you know, I threaten my patients. I tell them I love to operate, and the next operation is going to be a bypass surgery, and a bypass surgery is, you know, 3 hours long and 4 days in the hospital and four weeks recovery. And they say, well, I don't want that. And I said, well, then we have to do something different. We've got to, just because people, we can see them, I can see down the road what's happening to them, and if they don't change what they're doing, then they get an operation. And it's harder on them, but it is also limb saving at times.
Thank you. All right, so we're about to employ this next stent.
Can you zoom in on that a little bit more for us? Oh, we want to see the stent open up. Nice. Again, that's that thermoelastic metal. It will open as we deploy it.
Great. We'll take that balloon back and do a post-rotation. There we go, I have wire. Fantastic. So we're going to go back in with the balloon now, and touch up this stent, and then we'll be shooting our final shot soon.
Frank, you're doing great on time, so we're doing well here. Any other questions from the audience? Frank, you made it look easy. Made it look like you've done this 1,000 times.
Maybe. We like it. All right. Go up there. Yep. Keep going. Hey, it is good, I think. Good. Hold it there for a minute. Wonderful. You can come down. All right, so we see that stent kind of nice, it's smoothed out very nicely. Yep, got that open. Balloon coming out, we're going to go back in with our final catheter and shoot an angiogram here for the top. If you can see the two stents there, we have a nice overlap between the two stents. Can you focus in on that? There we go. Nice. There you go. Yeah, there we go. All right, screw lock. You can demag.
The fluoroscopic technology is dramatically improved. It's kind of like your TV from 20 years ago to what it is now. High resolution, low radiation. We can see so much better now than we could 10 years ago.
There's our final shot. Approximate the fade, looks very nice.
Looks
Keep
great.
coming down. Oh, sorry. I have to move the table. Run. Yes. Sure, we'll take a look at that. Yep. All right, keep coming down.
Frank, you happy with it?
Very happy so far. Yes, everything looks wide open.
Good.
Sections have resolved. All right, run. Yep, so now we have excellent inline flow here down into the popliteal, no further area of dissection. Go line. Come down and go below the knee. So now we just want to make sure everything is flowing here down to the foot, okay? Love it. Okay. Good. All right, and run.
Looks great, Frank.
Yeah, that's
Can you
very nice.
can
Very
you
nice.
zoom in and kind of show us the sheath and kind of what you do to manage embolization, potential embolization for this patient?
Oh, sure. We'll walk this off.
Anytime we intervene in the arteries, there's always a chance of knocking a little piece of plaque or
Yeah. got it.
knocking something free. And you can see
So
it's
here's, The sheath, we kind of open the sheath and let it drain. You can see the excellent pulsatile flow, and it clears the sheath of any potential embolization.
And it gives us a good sense that there's actual great pressure now and adequate flow to that
Yeah.
flow.
And
Frank?
now we actually, since we have the IVUS, we're actually going to go back in and take a look at our stent with the IVUS.
So next steps is after he does the IVUS, then the catheter, that little sheath comes out from the ankle. We put a special little bandage and compression on it. The patient would go to our recovery area for about 2 hours, hour to two. They get up, they walk, they go to the bathroom. They're fine to be discharged at that point. To be home and Easy does it for the rest of the day. That's what I tell them. Easy does it the rest of the day. You can see the stent. It's opening up and pushing against the plaque. That real bright echoes that on the rim is the actual stent. And it's kind of like we're driving through a tunnel. So think of a car driving through a tunnel. That's what we're doing with the IVUS. We can see with ultrasound waves, and watch exactly what's happening on the inside.
Thank you.
Frank, that looks great.
Yeah, wide open, very patent stent, excellent runoff to the foot. So very, very pleased with the result.
Excellent. I think we're going to move on with our next lectures to stay on time, but thank you. Perfect timing and great case.
Thank you so much.